So today I'm going to be talking about arteriovenous fistula. So what that is it's an unruly connection between an artery and a vein. So with normal blood flow, as you can see in this image right here, it goes from the arteries into the capillaries, into the veins, and back to the heart. Well, so what the capillaries are is they're the smallest vessels in the body, and they help transport the oxygen and nutrients from the blood into the tissues. So when you have an arteriovenous fistula, it's going to bypass those capillaries. So as you can see by this right here, it goes from the arteries into the capillaries where it distributes the nutrients and oxygens into the veins. Well, when you have an arteriovenous fistula, it goes from the artery straight to the veins and skips the capillaries so that there's less blood and oxygen and nutrients given out. An AV fistula can either be congenital or acquired. So what a congenital AV fistula is that it just means that the person was born with it, and that's very uncommon. Acquired means that it was acquired after birth. So this can come from a traumatic piercing injury, such as like a gunshot wound or a knife that pierces the vessels, and when they go to heal back, they heal together, which causes an AV fistula. And they can also be surgically created to make it easier to perform dialysis on people who have late-stage kidney failure. So some symptoms of an AV fistula are they can appear swollen and reddish and blue, similar to the varicose veins. And if it's a large arteriovenous fistula, it's going to go, and it goes untreated for a large length of time. A large volume of blood is going to flow under high pressure from the artery to the vein. Due to the veins not being able to withstand the high pressure, the veins are going to stretch, which is going to allow blood to flow more freely into the enlarged vein. That's going to result in a decreased blood pressure, which is going to cause fatigue, lightheadedness, or fainting spells. And since it's having to compensate, since the heart's having to compensate for all that blood, it's going to have to pump more forcefully and rapidly. And that's going to increase the amount of strain on the heart, which could eventually cause heart failure. And then very rarely, a large fistula can redirect enough blood from the affected arm or leg that it kind of causes numbness, pain, and cramping due to the Steele syndrome. And some risk factors are going to be, if you're a female, older age, cardiac catheterization. Certain medications can cause one, including anticoagulants and antifibrinolytics. High blood pressure and a high BMI are also some risk factors that increase the chance of you getting an arteriovenous fistula. And diagnosis, normally they're going to be able, what the doctor's going to do is they're going to take their stethoscope and they're going to be able to hear a humming noise because an AV has a very distinct humming noise that it makes. So if the doctor detects that, then they're going to order some more tests to confirm and determine how severe your AV is. So some methods of visualizing an arteriovenous fistula is going to be sonography, MRI, or angiography. So when you do sonography, you're going to want to image the vessel in a 2D image, and then you're going to want to measure the length of the AV fistula to tell how severe it is. And you're also going to want to capture the flow characteristics with color and spectral Doppler so that you can see the velocities in the AV fistula. An MRI can be done on more, it's better for deeper blood vessels such as IVC and the aorta. And when a fistula becomes so large that it requires treatment, they're going to have an angiography to look at it because they're going to inject a contrast agent into the blood vessels, which is going to help the fistula show up more clearly, and it helps to better assist in choosing what the best treatment option is. And treatments are going to be for a congenital arteriovenous fistula. The only treatment's only needed if they present with symptoms. And what they normally do is an ultrasound guided compression. And what that is they take the probe, they compress the fistula. It normally takes about 10 minutes. And that's just basically blocking the blood flow off so that it can kind of clot it up. And that's only going to work in about one of three patients. It's not very effective. And then if it's severe enough, the doctor's going to perform a catheter embolization to block the abnormal blood flow so that it goes in the right direction. A catheter is going to be used to inject cools and plugs into the abnormal connection. And normally it requires less than a day in a hospital, and you can expect to be back to your daily activities within a week. An acquired arteriovenous fistula usually has a single large connection that has to be corrected by surgery. So the normal connection is going to be cut, and the holes in the artery and the vein are just going to be sewn shut. So those are how they treat the AV fistula. And now I'm going to talk about the surgically created AV fistula. So this is what originally, before doing any research, I thought it was just surgically created. But so surgically created are used if a patient is going to require dialysis. They have to have an access point. So normally what they'll do is a pre-op evaluation to decide which access is going to be the most appropriate. And they normally use ultrasound, and they're just going to take a 2D image and add color to assess the flow within the vessel. And you'll also want to get the velocities to determine the extent of the AV fistula. And the four types of accesses that can be used are central venous catheter, an AV graft, which can be straight or looped, peritoneal dialysis catheter, or the most common, which is going to be the AV fistula. An AV fistula is most commonly preferred because they normally last a little longer than the other accesses. They're less prone to infection and clotting, and they can be relied upon for predictable performance. Sonography will be used to determine if the vessel is strong enough to support it, and there are three different types of AV fistulas that are normally used. The brachiosemino fistula, the brachiocephalic fistula, and the basilic transposition fistula. So what the brachiosemino is it's the most common fistula, and it connects the cephalic vein and the radial artery. And then the brachiocephalic fistula is going to be in the upper arm, and it connects the side of the brachial artery to the end of the cephalic vein at or slightly central to the level of the elbow. And then with a basilic transposition fistula, it's going to be a long incision made over the medial of the arm to cut the basilic vein up to the axillary vein. Then they cut in the cubital fossa and transposed into the subcutaneous tissue by multiple small cuts to perform the end to side basilic vein brachial artery channels. And this is a really good image I found. It talks about the different types of the arteriovenous fistula. So you're going to have the side of an artery to the side of a vein. You're going to have side of the artery to end of a vein, which is what the brachiosemino is. You're going to have the end of artery to the side of the vein, and then you're going to have the end of the artery to the end of the vein. So those are just different AV fistulas. And then my sonographic images just show how the velocities at the point of the AV fistula are they're going to be a lot higher. So this one right here is really good. It shows you the brachial artery at the beginning, before the AV fistula, and the peak systolic velocity is 350 centimeters per second. And then it shows you at the point of the brachiobasilic fistula, it shows you that the peak systolic velocity increases to 570 centimeters per second. And then after the AV fistula, the basilic vein is peak systolic velocity of 175. So that just kind of shows how it goes from high to higher to back to low, how it should be. And that's it.